What do you do when you have a patient who could benefit from making some changes in their life for their physical or mental health, but they just don't seem able or willing to do so? My name is Sean Kuhn, and I'm going to spend some time talking about motivational interviewing. This is something that's usually talked about in a half-day or full-day workshop, so today we're just going to spend a few minutes going over some highlights about the premise, the overall structure of an interview, and also touch on some of the tools that might be used. So what is motivational interviewing? It is a person-centered counseling style for addressing the common problem of ambivalence about change. So ambivalence here means that the patient feels two ways about something, and because of that, they're stuck. Now, we mentioned person-centered. Well, isn't everything we do for patients person-centered? Don't we try to come up with the best treatment plans and the best advice to give our patients? So this is not about giving good advice. By person-centered here, it means we're solving a problem of ambivalence and that this ambivalence is the patient's, not ours. So what are the reasons that we might want to use motivational interviewing? It's pretty well known for engendering engagement and trust, and it tends to create an appropriate balance of responsibility between the patient and the provider. It supports the patient's autonomy, and it increases intrinsic motivation, that motivation that'll help them to keep changes lasting longer. And with all of this, I believe it also can decrease some of the stress that providers experience with some patient interactions. So what is it for? MI is helpful wherever the person's choices and behavior are the primary factors in success. So here's a list of things: obesity, mental health, exercise, nicotine dependence. So there's research supporting MI in all of these applications and probably many more. But realize that this is not for your easy patients, and it's not a miracle cure for your more difficult ones. One way to think of it is it's a little bit like CPR or ACLS. You don't do it because you know it's always going to be effective. You do it because you want to give the patient the best odds they possibly could have to recover from their illness. So, why isn't this more widespread? Why don't we do this naturally? Well, the premise of MI will kind of give us a clue for that. The first premise is that patients are more motivated by their own words than yours, and that ambivalence is the key factor in change. So this really goes against the grain of a well-trained professional because it's very painful to have a keen insight into what a patient needs to do and not just tell them to do that. And the other issue is the ambivalence. So when we see a smoker with cancer of the lung, for example, or maybe a battered spouse, we have no ambivalence about what should happen with that patient. And because of that, there's sort of a sense that ambivalence isn't welcome, that they shouldn't have ambivalence. And so that ambivalence, however they may be experiencing it, sort of goes underground. So this is what's tough, is that we have an effective approach that could be very helpful for patients and actually be helpful for providers too. But to do it, we have to resist some pretty strong temptations of our own. So what is it like? The essence of MI is that you avoid confrontation and you avoid telling people or directing people in terms of what they should do. When you encounter resistance, you try to avoid it as much as possible. And empathy is very important in motivational interviewing, but it's not just the empathy that you might be emotionally supportive for someone or sympathetic for a person's situation, but it's a little bit more like insight. For example, when engineers are building a car, they have this term called empathetic design, where essentially they're looking at the steering wheel through the eyes of who's going to be using it and where would the buttons be and how would they want to use those buttons. And so empathy here is really about insight into the world and the experiences that the patient has. And so because of that, it really focuses on their motivators, their abilities, their ideas, and their resources. And here's the kicker: even if yours are better, even if your idea, your resource is better than theirs. The issue is that for this change to be sustained, it has to be something that integrates into their life. And so, in a sense, they're really going to become the experts on how this change is going to happen. And so that's why a lot of the focus is really on them and trying to empathetically understand the circumstances that they live under. So, ambivalence. This is going to come up a lot in motivational interviewing because it's really the key issue in change. And in MI, ambivalence is normal and it's welcome. But unsurfaced ambivalence is sort of a motivational quicksand. For example, I want to exercise more in the evenings, but I also want to spend time with my kids at that time. Or I usually take the medicines my doctor's given me as prescribed, but sometimes I remember that this is the same medicine that my grandfather started taking just before he died, and sometimes I wonder if it's harmful for me in some way. And so we have to realize that we never completely know what we're asking a person to do when we're asking them to make a change. For example, I may be asking someone to stop drinking, but the reality is that their spouse is an alcoholic, their spouse isn't going to stop drinking, and for that person or that patient to stop drinking, they'd have to leave or separate from their spouse. Or I might ask a young lady to stop smoking and tell her that it's a great idea, it'll prevent her from having cancer and so many good things. But in her mind, I might be asking her to gain weight and to not get asked out on dates or maybe spend a lonely life. So you see, this ambivalence doesn't have to be rational to be powerful. And so that's why it's really important to surface this and have conversations about the ambivalence so that those things can kind of be looked at and then resolved. And I have a saying about ambivalence, and that is that powerful reasons are more important than important reasons. So I'll give you an example. I could spend years telling my patient that he should stop smoking because he might get cancer someday, right? But he doesn't really change until one day he starts dating a girl and she doesn't smoke. She doesn't want her car to smell like smoke. She doesn't want her house to smell like smoke. And for that period of time that he's dating this girl, and it may only be 6 months, I mean, he may move on to another relationship, but during that time, it is powerfully inconvenient for him to continue smoking. And sometimes that's the type of thing that can help a person make a change. It's also the type of thing that can keep a person stuck. So we have to realize that there's these powerful reasons and that the patient holds them. They're the ones that know the powerful reasons and the barriers, and it's sort of getting to that that helps to resolve this ambivalence and help move towards change. And when we completely ignore the ambivalence, we actually decrease motivation and we're kind of avoiding some of the insights that we might find if we dig a little deeper. So just to summarize, patients' words are, in many cases, more important than our own in these interviews. We want to avoid resistance and get out of the way. Expert listening is more important than giving advice. And that ambivalence is very, very, very important in the process of creating change. So, you're coming to work, you've got your coffee, you've got a skip in your step, and then you see that name on your schedule. In this case, maybe it's a patient that just is pretty passive about their health care and just don't tend to get better. Or maybe it's a difficult and demanding patient that you really don't always know what to do when they come in. So you want a positive strategy to somehow get through this visit and not lose your gumption for the rest of the day. And you also want to give the patient the best odds you possibly can for their recovery from their illness. So what should that visit look like? So in motivational interviewing, there's 4 stages. There's engaging, focusing, evoking, and planning. And one of these stages is optional. Can you guess which one that is? So with motivational interviewing, it's actually the planning that's optional. In a patient-centered interaction where they're going to be coming up with a plan and doing much of the work, that planning might not even occur in the first or even some subsequent visits. Now, this is very contrary to most of our training in health professions. Usually, our training is really about focusing, figuring out what the diagnosis is, and drilling down to that, and then revealing the plan or the treatment. And that's very, very, very different than approach that you're going to have for somebody who has a chronic problem, that they're going to have to change behaviors over a long period of time. In that case, the more important pieces are engaging and evoking. And evoking in this case, we'll be talking a bit later about something called change talk, which is something that will help us with that. So great. We've flipped our approach. We've given you sort of a new one to approach people having chronic conditions or things that require behavior changes. But I have to warn you, there are some pretty big traps that can throw this whole process off. There are a number of interviewing traps. There's an expert trap, where we are seen as the expert. There's an assessment trap, where the patient gets the sense that there's going to be a number of questions and that their job is just to answer them. There's a premature focus trap. That has to do with our skill of going straight to the issue as trained professionals. And there's a writing reflex where we correct the patients in the middle of their explanation of something. And there's a labeling trap, which kind of ties into our ability to diagnose people and say, well, this is an alcoholic, for example. So you could probably see why these traps are kind of like flypaper for professionals, because all of this comes from our training. This is what we're good at. And so what do you do when some of your best skills may be a barrier for change for our patients? It's a challenge. So let's take a look at just one of these traps, the expert trap. So in the expert trap, we say things like, you should, or what you ought to do is, or, you could die if you keep doing this, or think about your family. So that's considered the expert trap because we're seen as the expert. And in doing so, we're actually taking on the responsibility of how well they do. And these are things that I am great at. This is a big trap for me because it's very easy to solve, warn people, give them advice, try to persuade them, beg, confront, shame them, plead, anything to try to get their attention about something. But these actually can be demotivating. And sometimes we'll see a later effect where, years pass and the patient isn't making a change, and we feel like we're working harder than they are, and maybe the patient has become even more and more passive. And this is a phenomenon we see across healthcare, and in part it might be because we're trying to be the expert with something that is so dependent on the patient's behaviors that we really need to find a way to get them into an expert role so they can begin to find solutions that will work for them in their life that they're living. So we know the overall structure and shape of the interview, and we're aware of some of the traps that we can fall into. But how does this conversation actually go in real time? So we'll talk about something called OARS, and we'll talk about something called change talk. So OARS is an acronym, so open-ended questions, affirmations, reflections, and summary. Now, we're not going to talk too much about open-ended questions because everybody's pretty familiar with those, except to say that it's important that we are choosing these open-ended questions very intentionally. And we'll be using specific types of questions that can engender what we call change talk. Okay. So moving on, we'll talk about affirmations, and this is really catching them doing something right. So let me tell you the problem with affirmations. The first problem is that we do them far too rarely. And the second problem is that when we do them, we overdo it. So this isn't about cheerleading. This isn't about saying, wow, you're just such a great person, or Wow, you're very intelligent. This isn't about that. This is more specific and sometimes even more subtle. I can tell you've been really thinking about this issue. It sounds like you've been successful at making some other changes in your life. So it's important to have these affirmations in motivational interviewing because as you get more involved with motivational interviewing, it actually has some teeth to it. It has a sharp bite. There is a bit of pain that patients experience when they're dealing with their ambivalence. And to help them get through that and stay engaged with you as a provider, these affirmations can really serve as sort of an anesthetic to make that surgery go a little better and a little more comfortably. So, reflections. So, this is where you're really giving the patient back what they said. You're rephrasing it, but you can also reflect a feeling. For example, and this really worries you. So, the key thing with reflections is that it has a downward inflection. So, the sentence goes downward in tone. And this is actually pretty challenging for people that live in a West Coast culture because we often finish our sentences with a question. We go to the coffee shop and we say, I'd like to get a coffee and a bagel and some cream cheese. And that's kind of the opposite of what we want to do here. We want to end our sentences. Basically, we want to take sentences that could be a question, turn them into a statement, and then give them a downward inflection. And if there's only two things that you ever learn about motivational interviewing, it's these reflections and it's change talk, which we'll also talk about. Now, there is something called a double-sided reflection. For example, you think you use too much at times, but you also don't really think of yourself as a problem user. So, double-sided reflections are how you develop discrepancy between the patient's various values and some of their behavior. And it's very, very crucial still to have that inflection go down. I'll give you some examples. So, you're afraid of getting cancer, but you can't seem to stop smoking. Or your depression is really holding you back in life, but you're still hesitant to take medications for it right now. Now, can you imagine if I said that with a question? So, your depression is really holding you back in life, but you still don't want to take medicines for it? So, you can kind of see how turning it into a question makes it sound sort of judgmental. And basically, it sounds like you're saying, we shouldn't even be talking about this, right? Which is exactly what will put that ambivalence back underground. And we know the dangers of that. So double-sided reflection is very helpful, but you still have to use that downward inflection. Now, summary statements are kind of a type of a reflection, but it's really a collection of things that the patient has said. And here's the key point. It's not a perfect transcription of what they said. But what you do is you very intentionally choose what you're reflecting. I'll give you an example. So you're finding it hard to stop smoking, but sometimes you do think about stopping because you're worried about your grandchildren and whether you'll be there for them. And you have a friend who has stopped smoking in the past, and you haven't talked to him in a long time, but you're willing to give him a call and maybe see how he did that. So basically, we're taking all the statements that we may have found throughout the discussion and we're picking a bouquet, certain ones. And we pick that bouquet and they go home with it. And sometimes that helps to really kind of firm up some of the comments that they've made and some of the ambivalence that they have and some of the discrepancy between the things they really value in life and some of their own behaviors. And so these summary statements can be very helpful. But once again, it has to be empathetic, non-judgmental, and using that downward tone inflection is often very helpful to accomplish that. So earlier, I suggested that I'd share something very important called change talk. What is it? So far, what we've talked about sounds kind of passive. I mean, we're all great listeners, So, what is it that makes MI special? Part of that is change talk. So, change talk is whenever a patient expresses recognition of a problem, concern, benefits of making a change, or even an intention to make a change. And recall that ambivalence is very key, and that also their words are probably more important than our words in terms of sustained change. So, what we do is we use open ended question to elicit some of these expressions. So, basically, we're not asking them to change, we're actually changing what we ask. And how do we do that? So, somebody came up with this acronym, Darn Cat, but it talks about desire, ability, reasons, and needs. So, you might ask a question like, how would you like for things to change? Or, what worries you about your depression? What concerns you about your nicotine use? Does your spouse have any concerns about your drinking? If you were to make this change, how might you do it? So, eliciting change talk also has the cat part, which has to do with questions related to patients that are closer to making a change. Questions like, what do you think needs to happen next? Or what are you thinking about doing at this point? Or how are you going to do that? And realize that the answers to these questions will probably be answered with an I. Well, I would do this. Or I worry sometimes about this. Or I think this could help me. And so you see that you're actually connecting people to their own values. You're helping them hear themselves speak in a language of change. And you're also helping them speak in a language of responsibility, especially when they're making a lot of these I statements. And that's entirely appropriate when you're dealing with a chronic disease or any disease that requires a lot of behavioral self-care on the part of the patient. These are the types of questions that help to elicit that. And the reason you want to elicit that is because you're going to collect that and you're going to reflect that back to the patients at a later time. So that's all well and good. But what if they don't respond the way that we expect them to or want them to? What if they say, I'm not the one with the problem, if only my spouse would stop nagging me? Or these people are just exaggerating. I've never hurt anybody with my use. So we call that sustained talk. In other settings, you might call it resistance or denial. And you remember in MI, we try to roll with resistance. But I have to tell you that a lot of times these types of statements are really an emotional trigger for us. And they're sort of a juicy worm. They are very attractive to professionals who want to jump in and debate or educate around this issue. But our goal is to basically reflect what they're saying in an empathetic and fairly detached way. So there's a lot of people that are concerned, but from your point of view, it's not really hurting anybody right now. So when you're getting this sustained talk or this resistance or denial or however you want to call it, the goal is to get out of the way. Maybe come alongside or agree with a twist or try to shift the focus to something else. Or just emphasize the fact that they have personal choice and control in the matter. And what you don't want to do is let them practice resisting. Because realize ambivalence has two sides. There's a pro and the con that's always battling in their minds. So what happens if you, the professional, is always pushing one side? Who's left to push the other side? So that's the issue, is that either out loud or in their head, they may be building more resistance. The more we try to push, advise, or kind of push back against some of the sustained talk or resistance that we hear. So we don't want to give them any resistance training at all. We want to just get out of the way. So we've touched on a couple types of interactions and skills we might use in those interactions, but there's a whole list of other things, and we won't go over them now, but there's a number of other things that can be learned and mastered through some training or reading in MI. But I just want to stop for a second and recognize that we've introduced this topic. We've shared a little bit about the structure and how MI works. So I think a take home is that across the world, chronic disease and mental health issues are becoming the big challenges of our time. And we're beginning to realize that we've been trained in a way that suits only about half of our patients and doesn't really serve us well for these chronic diseases and the behavioral challenges that patients face. So, other places to learn more about this, there's books, there's hundreds of online videos. Workshops are fun to go to, and there's websites sort of all over the internet about motivational interviewing. Here's an example of some books you might look into and some videos you could take a look at, but literally just searching motivational interviewing will give you many more examples. But just to summarize, in making long lasting changes, ambivalence is the key. You're not going to get anywhere without unearthing and dealing with and resolving the ambivalence that's keeping people stuck. If you experience denial or resistance, find ways to get out of the way. What you ask is probably more motivating than what you tell. You want to evoke change talk from your patients. And you want to catch them doing something right. No cheerleading, but just simple insights and noticing strengths that they may have, steps that they're taking, or even intentions to change that they may have voiced. And reflections are golden. They get you out of a million situations, but just remember to use a downward inflection when you use them. And lastly, if you must give advice, do it briefly, do it at the end, and ask permission first. So I hope this was helpful for you, and I hope that you learn more about it and have some great patient interactions.